Capitol Report is a production of Senate Media Services.
The Senate's two physician senators describe measures to bring transparency to prescription drug pricing, improve the patient-doctor relationship, and expand insurance coverage in the individual market, plus greater access to mental health services. Stay tuned for this week's Capitol Report. Welcome to this week's program. I'm Shannon Lurkey. Two healthcare-related bills unanimously passed the Senate last week. One to license and regulate pharmacy benefit managers, and the other to allow direct primary care services between patients and physicians. Joining me to talk more about the measures is the chief author, Senator Scott Jensen. Welcome.
Thank you, Shannon. It's nice to be here.
When we last talked about these bills, they were in the early stages. So let's start with licensing and regulating pharmacy benefit managers, or as everybody says, PBMs. Why do it?
Well, a pharmacy benefit manager, or a PBM, originally came about in the 1960s, and they were there to process prescriptions. But with the advent of Medicare and medical assistance in the 1960s, things started to ramp up. So in the 1970s, PBMs were now starting to decide what drugs would be on an accepted formulary for whoever they were working with, whether they were working with Blue Cross or Health Partners or Medica. And as we move forward, we saw the PBMs have an increasing amount of power. They started to do negotiations with the pharmacies on behalf of the insurance company or the plan sponsor. Maybe it was a big company like Target that self-insures. So PBMs became very powerful. They wielded a lot of authority. They decided what drugs would get on the formulary. And you can imagine if a drug wasn't going to get on the formulary, the manufacturer of a drug would say, Mr. PBM, what do we need to do to get on your formulary? And the PBM will say, well, we could probably negotiate. You could make a better bid and give us a better price. And by the way, there's this matter of rebates. That would be another way to sweeten the pot. Meanwhile, the pharmacist downstream from the PBM was being told by the PBM, we will let you keep much of the money that you collect from the patient, but we will be quarterly sending you invoices. And that's clawbacking. So they would claw back dollars. Then the PBMs would say, we will pay you, Mr. Pharmacist, such and such, maybe $10 for a prescription of amoxicillin. But in the meantime, they would charge the plan sponsor or the insurance company $40. And that was called spread pricing. So between spread pricing and rebates and clawbacks, pharmacy benefit managers became billion-dollar industries. And the odd thing is that the insurance companies started to buy the pharmacy benefit managers. So now the three big PBMs, Optum, CVS Caremark, and Express Scripts, they do more than 90% of the business in the world. Then you add on this substantial sized Prime Therapeutics, probably the fourth biggest in Minnesota. Those are four PBMs. They're all owned by an insurance company.
And so the theory is that one of the reasons why prescription drug prices are getting so high is that all of this stuff is being done in the background, and we don't really understand what's going on, what's driving all of these negotiations.
And enter the scene, the PBM bill.
Okay.
Removes the gag clauses, introduces transparency, defines terms, tells the PBMs these behind the scenes operations, no more. You will demonstrate what the pricing is so there won't be any hidden spread pricing. You will not be able to claw back from the pharmacies without making it more clear what you're asking for. Plus, you'll respond to the Commissioner of Commerce. You'll act on behalf of your plan sponsors. You'll deal fairly. We also go on to allow patients to synchronize their medicines once a year without any cost to them. We also allow pharmacists to work to the top of their license by going ahead and substituting bioequivalents if the physician isn't available and they prescribe something that isn't on the formulary. A lot of things will bring to the light of day how PBMs work, and that will translate right away into more transparency. But down the road, we will see dollars being saved because PBMs will no longer be able to play games. And the pharmacists, right now, if you went in to get your 10 days worth of amoxicillin, you might put your insurance card on the counter. And the pharmacist would say, okay, that'll be $40. But if you look the pharmacist in the eye and said, well, if I just paid cash, what would that cost? And they would say $8. And you'd be shocked. because the pharmacist can't offer that information on a voluntary basis. You have to ask. We're changing that.
So this will shine a flashlight on. The bill passed the Senate unanimously. It is moving in the House. What do you hope will happen?
I was hoping there'd be bipartisan support in the Senate, but it passed 67-0. It grieves me deeply that this bill in the House isn't moving on the same pathway. As of this point in time, we're being told it's been put into the omnibus bill along with another couple hundred bills and more than 1,000 pages. This is a new chapter of law in state statute. This bill deserves to have not a flashlight, but a bright shining spotlight right on it so everybody can understand and everybody can engage what we're trying to do. I'm hoping that that can happen so then we could go to conference committee, make it better, get it to Governor Walz, and I think he would sign it in a heartbeat.
Since you're here, I'd like to talk about the other bill that also passed unanimously, the Direct Primary Care Services Agreement. Can you explain what this bill would do?
This bill is actually trying to go back in time. This is saying, you know what? Patients and physicians can have relationships apart from insurance companies. Insurance companies, as a middleman, have a role. But when it comes to the everyday care of a sinus infection or a physical exam or a tetanus shot or having a wart frozen, these kinds of things don't necessarily need to go through this middleman with all the veiled secrecy and the various and disparate fee schedules. This is simply saying, Mr. or Mrs. Patient, you pay $70 to Clinic XYZ every month, and they'll provide the cares you need. They'll provide 24/7 access. They'll manage your medications, any office calls you need during the course of a year, whether it's 5 office visits and a physical, or whether it's 2 office visits and no physicals, whatever you choose to make it, they'll be covered. There'll be no co-pays, co-insurances, things like that. What it doesn't do is it doesn't do anything outside the clinic. What goes on in the clinic walls, for the most part, will be covered.
You said that this bill would allow this practice to be legal. Currently, there's some reasons why you can't actually do it. Would you, as a physician, want to offer this kind of service? And what about physicians who are part of clinics where, insurance is part of the business model? So I assume this factors the business model of how billing and insurance and everything else happens. So can physicians actually make these arrangements in a clinic setting, or do they have to have their own side practice? Like, how does that work?
You can do direct primary care right now, and many clinics do, perhaps as many as 12, 15 in the state that I know of. This bill is just trying to clarify that this is not an insurance plan. That's the first step. Once we do that, then we could potentially use these dollars down the road, if we modified the bill, to be paid for from HSAs. One of the challenges that we'll have down the road is if you're going to get all your services from a clinic and you've got a big deductible with an insurance company, those dollars that are paying for all your clinic services should really go against your deductible. That'll be a step down the road. But for now, we're just trying to say you can have a relationship, you can secure an agreement, and it isn't insurance, and the Commissioner of Insurance isn't going to interfere. So you don't have that 15 to 18% administrative cost. Would I do it myself? I would seriously consider it. And if I did it, it wouldn't be instead of my regular practice. I would have insurance, I would have Blue Cross Health Partners, Medicare, medical assistance, and then alongside that, I would have patients say, we'd like to have a direct primary care relationship with you, and we'd like to sign an agreement. And I would look at that.
So the first step, as far as you're concerned, is that this is in addition to insurance. We still need insurance, though John Marty has long been an advocate of just getting rid of the middleman across the board. Could you see that potentially happening down the road?
This isn't anything to do with the hospitalization costs. Most people want insurance to cover the heart attacks, the appendicitis, the stroke. They're not concerned so much about the everyday stuff. I don't have my individual uninsured patients coming in worrying about what the cost of my office call is going to be for a sinus infection. They're worried about having a heart attack or an appendicitis, and they want a catastrophic package that will make it so they can have something like that happen to them or their family member without having to get a second mortgage on their house. That's what people want.
Senator Jensen, thank you so much.
You're very welcome.
According to Governor Walz's budget blueprint, his proposed healthcare reform, ONECare Minnesota, would offer health coverage options, encourage stability in the individual market, provide consumer choice, address rising healthcare costs, and improve the healthcare experience for all Minnesotans. Joining me to talk more about this proposal is physician and Senator Matt Klein. Welcome.
Hi, Shannon.
You offered the governor's ONECare proposal as an amendment on the Senate floor last week. What is ONECare?
So first of all, it's important to talk about what the problem is in Minnesota. A lot of people get their health insurance through their job or possibly through a public program, but there's about 100,000 people who just go out on the individual market and try to buy their own insurance. And for those people, their premiums are unattainably high, and their deductibles are so high that they often don't even seek care. It tends to be individual business owners or farmers. And Governor Walz's ONECare option is a public program. It's an insurance product that we already offer to people in the form of Minnesota Care, working poor people, that would be available to everybody, that they would be able to purchase a health insurance product from the state that would give them platinum level coverage and cover their health care needs, and it would be sustained by the premiums that individuals pay.
If I understand correctly then, this is not an extension of health insurance for all or single payer, because I think sometimes that gets confused, but as you said, it is a program just for that subset of people. But this is that same subset that the Republican proposal that became reinsurance that they would like to extend is also tackling. So why move in this direction? Why not continue with reinsurance?
We spent $300 to $500 million, depending on how you calculate the numbers, on reinsurance last session. And that was actually paychecks that went right out to insurance companies in the hopes that they would hold down their premium rates. And it worked to an extent. They brought down rates about 20%. Governor Walz feels, and I feel, that we don't want to continue indefinitely giving big paychecks to insurance companies. We would rather try to give reduced cost to individual Minnesotans or offer them a product that they can afford. ONECare is a public product, but it's an insurance product. It's not free health care for all. It's not Medicare for all. It's an insurance product that you would buy from the state and that we know through our experience with Minnesota Care offers quality, high quality, and affordable health care for people who purchase it.
Last week, Minnesota Management and Budget Commissioner Myron Franz was on the program, and we talked a little bit about ONECare. He said it won't be fully ready to roll out for a couple more years. Is it possible that reinsurance could continue until ONECare is available, or does a choice need to be made now?
Something needs to be done this session, because those people in the individual market can't wait while we figure this out and continue to pay premiums of $30,000 a year. So if reinsurance ends up being what we do to bridge to ONECare, that may end up happening. There are other proposals. The governor has also proposed direct rebates to people in the individual market. Rather than sending money to insurance companies, send money to Minnesotans. That's a good option. We do need to do something, but we need to commit that whatever that bridge is to a full solution like ONECare is just a bridge, and it's not something that we're doing forever.
Under the plan, platinum level coverage would be available for purchase anywhere in the state, and those plans cover 90% of a person's costs.
That's right.
Gold and silver level plans would only be available in areas where there is not adequate commercial options available. So there's sort of a tiering and decisions about who gets access to what. What's the rationale behind that?
So I think the governor was quite conscious to choose a platinum level product because he didn't want to interfere with the individual market as it exists here in Minnesota. Right now there are not platinum level products available from most health insurance plans in most parts of the state. This would allow that. This would provide a public option that has platinum level coverage, which means very low deductibles and very low premiums. Sorry, very low deductibles. And in any case, in the backup situation, where maybe the plans abandoned a certain part of the state geographically, which they have done before, and offered no products in a part of the state, why then we would step in with gold and silver level products in those areas, just to cover a deficit, basically.
So if you're a farmer in an area of the state that has a lot of insurance competition, you would have the option of buying the platinum level ONECare, and also any others that are commercially available.
That's
if
right.
You're in an area where there are very few options, you would have the option to buy a lower level plan, but you would have access to a healthcare marketplace, essentially.
That's exactly right. And the plans sort of abandon a certain county in the state, which again has happened before, far western or rural parts of the state where all of a sudden there are no private health plans at all. then the state would jump in with a Minnesota Care type product that would allow you to buy a gold or a silver plan from the state in those areas. Candidly, I think we should be doing that right away, and I think it really improves our leverage in encouraging the plans to continue geographic coverage throughout the entire state.
On the Senate floor, it was mentioned that this is an extension of government-controlled health care. Critics say that when government gets involved in healthcare and creates more programs, then they take on a life of their own. How do you counter those who fear this is just one step among many towards government-run healthcare? Well,
first of all, let's look at how well the private industry has done at providing healthcare. Health insurance plans really have only one job to do, and that's manage financial risk and set out their costs in an actuarial way so that they don't get into trouble. And now we're doing that for them. We're giving them $500 million basically to cover their financial risk in the health insurance market every single year. And so if we're doing that job for them, then what function are they really performing any longer in the state? They're certainly not holding healthcare costs down, which was one feature they were thought to bring to the table. And so it's possible that government can do those jobs better. Candidly, I think we're already doing them largely ourselves by programs like reinsurance and so forth. One thing I can guarantee is that the Department of Health, the legislatures of the Capitol, are more interested in providing health to Minnesotans, health care to Minnesotans, than they are in reaping profits or building their business or expanding into a new state. And the same cannot be said of the private health insurance industry.
Yes, they do have to make money. Last week, since I've got you here, I want to talk about one more thing. The Senate unanimously passed a bill to license and regulate pharmacy benefit managers. As a physician and as a senator from the other side of the aisle, why is this a good idea?
Oh, it's a great idea. And most people who are watching the show won't even know what a pharmacy benefit manager is, but they are huge corporations that are middlemen in the interval between when a doctor writes you a prescription and when you go to fill that prescription at Walgreens. And they set your formulary, which drugs will actually be given to you. Sometimes they choose more expensive drugs or older drugs because they're getting a rebate from the drug manufacturer. And all of those negotiations and business dealings are invisible to the patient and to the doctor that's trying to keep down costs and so forth. What Senator Jensen's bill did is just shine a bright light on all of those transactions so that we can at least start to study who's getting money for what? Are we really holding down healthcare costs? Are we really providing the best medications for the dollar? And again, I don't think that pharmacy benefit managers are as interested in that as they are in sort of cutting the best deal with manufacturers that they can get. So in order for us to at least try to drive us towards higher quality and lower costs in this state with drug prices, we're going to need to shine a little light and regulate the pharmacy benefit managers a bit.
Senator Matt Klein, it's always a pleasure. Thank you.
It's my pleasure, Shannon.
A few weeks ago, I spoke with both an international energy expert and Senator David Senjem about Minnesota's clean energy future. This week, I asked Governor Walz why free market principles aren't enough to move the state toward clean energy.
If there was truly a free market, but we know there's incredible pressure comes down that you see it, whether the fossil fuel industry is not going to give up market share on their own, they're simply not going to shift. In a perfect world, that would be wonderful. Adam Smith's hand would step right in and we would have equilibrium in a market. It's not going to happen. It takes vision, leadership. You have to set these goals, and I'll give full credit. In 2007, that visionary leadership that Governor Paulini and the legislature set in motion that rocketed us above others. They surpassed the goals they were going to meet. The critics then said, oh, there's no way by 2025 we'll be anywhere close to that. They've already surpassed them. They met it, and that's as the acceleration of technology. So, yeah, in that perfect world, the market would work wonderfully, but there's going to be a distortion of that. There'll be the folks who will push back about this. Before I even had a 2050 plan out, before they spoke to any CEOs, I don't know what the politics are here. I'm guessing that maybe some of my tax proposals would not be as popular with some folks up here. That's a different discussion. Those are things that talking about this is the industry itself and what's going forward. These are folks that have said in the market, give us a chance to compete, let us get on level playing field, and guess what happened? We were always told that the problem with solar energy was they would never meet cost parity. with other forms of energy. Well, they did it and they got below it. So I remain hopeful. I do believe there's a role, and that's why I'm surrounded by private sector CEOs and leadership, that the market can work as long as we give them a fair opportunity in that. And I think our 2050 plan starts to level that playing field. And as I said it, and I'll continue to say it, there are no U.S. Navy carrier battle groups patrolling the solar fields outside of Owatonna. So the subsidy that goes to oil that we hear about, solar's holding their own. They're doing it, and the price continues to come down, as does wind, as does some of our new technologies.
The National Alliance on Mental Illness says that 1 in 5 adults experiences mental illness in a given year. And a recent Pew Research survey reports that 7 in 10 teens say anxiety and depression are major problems among their peers. Joining me to talk about proposals to improve the mental health of Minnesotans is Senator Julie Rosen. Thanks for being here.
You bet.
Senate File 1 is a broad package of proposals that are directed at improving access to mental health services. You said at the press conference that it rebuilds the system. What do you mean?
Well, what I mean is we have a system in place, but we are helping that system expand and get to the areas that need attention. And obviously, mental health is Senate File 1, and you hear everywhere you go, whether it's in the schools, whether it's in the ag community, it's in working with youth at the county level. I remember my county commissioners, they used to come and talk about potholes, funding for roads and bridges. Their number one issue now is mental health. They all say, please do something to help us with mental health. It is at a crisis level. So Senate File 1 is directing significant dollars to all these areas. $25 million, right, to all these areas that we can make a difference in. So we're helping that system build up and support the needs out there.
So I'd like to walk through some of the groups that are targeted. First one being schools, both K-12, college, youth. In general, there's a number of ways that this bill would tackle the mental health of those. Can you talk about some of that?
Back in 2007, we started the School-Linked Mental Health program. Been very successful. However, we just don't have enough therapists, providers out there to go into the schools. So we are expanding that program with some significant dollars to make sure that right now we can only get to 52% of the schools, that we can get to 100% of the schools. And we're also going to include telehealth with that. So the parent and the child have their initial visit with that provider, and if they all agree upon services being provided by telehealth at the school in a secure location, they can have ongoing services. Because we've seen, especially out in the rural area, it's very hard to get to these providers that are a long ways away. They can't come down to the school, so there's a missing link there. And we can do a lot of these services through telehealth. We've also heard the stories about the long lines out of the clinical services at our university system for mental health. And that's another area that we need to provide more money and also provide those services through telehealth. These kids nowadays are ready. They're adapted to a phone or their computer, and it's been quite effective to provide services that way. We're looking at it that way with providing support for our ag community, because we have one provider that travels the entire state, and I believe he's 70. He's about ready to retire. We need to get him some more help, and we need to be able to get out there, because as you know, the ag community is stumbling, and the Commissioner Peterson this morning said in Finance Committee, $26,000 is their average salary right now. And it is their number one issue right now is mental health for the ag community.
And on previous programs, we've spoken about efforts to target farmers and their mental health, and there's still a need. And so this bill would further expand that and potentially hire more people to work around the state, but also this telehealth, so sort of a secure way of reaching a mental health professional without having to travel miles and miles to do so.
Absolutely. We just don't have enough providers, mental health providers out there. We have a deficit. So in order to spread our resources more widely, we could do that through the telepresence. Senator
Senjum spoke of the Yellow Line project. So this is another area that would receive funding. And this particular project originated in your district,
Yes,
I believe,
yeah.
and has won a National Achievement Award. What is it, and how will it be expanded?
Well, it's the Yellow Line project. It started in Blue Earth County. Big kudos to those folks down there that started this. They basically give an assessment to somebody that's on the road to being arrested, see if they have mental health needs. And so instead of throwing them into jail and not being able to provide services to them, they divert them into a program and give them services. Highly successful. And they are ready to, with some appropriation, some help from the state, model that or copy that program for other counties that are interested in it. And there's quite a few that are interested in gearing it towards their specific needs. So it is something that is really humane.
Well, and there's a growing awareness of people finding themselves in the correctional system that are there due to addiction or some other kind of mental health issue. So this would put them on a different track to recovering their health as opposed to incarceration.
Absolutely, and that's what we need to do. That's not fair for them. It's not fair for anybody to be jailed and not have the appropriate care.
At the press conference where you and your caucus members talked about so much of this, Senator Goggin spoke of funding a landlord risk mitigation fund and also supportive housing grants for people as they wait for Section 8, federal Section 8 housing vouchers. So why is this important? It's sort of a bridge type of housing, or?
Right. Well, we just working with the mental health community that serves this area, they have said affordable housing is the #1 issue to make sure that these people that are suffering from mental health, mental disease, are stable. You need to get them affordable, stable housing, and you need to provide transportation. Transportation has been a little more difficult issue to get our hands around. That's very complicated, but affordable housing, we can support that. So that's what we need to do, make sure they are in a supportive situation, environment.
Well, and a stable place to live is very important for a person's mental health. And so there's also some money for homeless youth, is that correct?
Yes, very excited about this program. This is the Shelter-Linked Mental Health Program. And we are directing services right into the shelter and also providing that through telepresence if these teenagers would like to have that. It's a win-win, but we need to get these youth some care. Significant care.
And one more thing then before we have to go, mobile crisis centers, what are they and will they be expanded?
Yes, they're very successful, and again in Blue Earth County were one of the forefronts on doing mental health mobile crisis centers, and they send them out. They're like on call and they're sent out. Unfortunately, the state has taken some of their funding away to expand other areas of the state, and we need to support the ones that are up and rolling and are doing significant work, getting right in there, and it's like a EMT for mental health.
$25 million, very quickly, is it enough? Good start?
Oh, I would love to have more. I do think this is an area that we can make a significant difference, but $25 million shows that we are serious about this issue and we are going to do something about it.
Senator Rosen, thank you so much.
Thank you, Shannon.
Join us again next week as we delve into more topics affecting Minnesotans. I'm Shannon Lurkey, and on behalf of all of us at Senate Media Services, thanks for watching.